discussion about we'll guide you through the Adobe Connect screen that you're seeing on your monitor, and then we'll go ahead and introduce our speaker. I've got this cute little arrow I'm going to try to use that will point to the different modules. Here you can see the people attending. The next one is more important. It's the files module. You can download different files from that just by clicking on them. You'll see that we've got the presentation file, and we've also got the save the date postcard for our upcoming conference, which we'll talk to you about in just a little bit. Down at the bottom here, we've got a web links module that gives you can click on those and get to our telemedicine conference website. You can sign up for our newsletter. You can view open mic recordings from the past that we presented, and you can take a survey of your impressions of today's presentation. Martha has found a way to be sure that everyone gets a copy of this SurveyMonkey survey, so it'll appear on your screen at the end of today's presentation. And we ask you to go ahead and fill that out, and especially to tell us what you'd like to see coming from us in future webinars. There's a chat module down below. If you find that you're having technical difficulties, please ask your questions of Martha and me in there, and we'll try to fix the issues. And then over here we have a question and answer pod. In here you can enter your questions for Wes, and he'll kind of monitor that as we go along and kind of keep track of what's going on and answer questions as appropriate. I want to be sure that you know that our next webinar coming up in February is going to feature Libby Chewy from the Association of Utah Community Health Centers, and she'll be talking about telehealth use in community health centers, and we're looking forward to seeing that. And then just a last-minute reminder, early bird registration for our conference in Portland, Oregon in March ends tomorrow. So you want to be sure you get in and get registered, and you can save a little bit of money, which is always a good thing to save. So let's go on and get going here. I'd like to welcome Wes and thank him for taking time to present today, and I'd like to give you just a little bit of information about Wes. Dr. Wesley Valdes has served as Telehealth Services Medical Director for Intermountain Healthcare, and I'm going to refer to that as IHC after this because that's what we used to call it when I lived in Utah, since November of 2011. Since his arrival, IHC has launched online physician service, hosted demonstration booths at HIMSS, HIMSS, the American Telemedicine Association, and the mHealth conferences, and he's engaged in building software solutions for inpatient remote monitoring. Dr. Valdes has helped to get telehealth reimbursement language adopted with Select Health, which is the healthcare insurance company owned by IHC. Dr. Valdes worked in collaboration with Intermountain Healthcare's Healthcare Transformation Lab and helps guide the organization regarding how to adopt telehealth strategies and technology to support organizations, their missions and values. And if that isn't enough, Wes is also a member of the NRTRC Advisory Board. And just one quick note, we are recording this session so you and your colleagues can go back into our website and look at it in the future. And with that, Wes, take it away.
Thanks, Bob. Just a quick audio check, making sure you can still hear me. Okay, I had to be worried there for just a second. So again, welcome everybody. And I do want to encourage everybody to either ask questions or post questions in the Adobe. My presentation is going to, I'm going to try to do it somewhat quickly to try to leave as much time for questions as we can. But certainly, I'm informal enough that if somebody wants to ask a question in the Adobe application here, I can try to work that into the presentation as I talk. The topic I wanted to address today is online care, which I guess is a little bit of a nuance from the things that most of us probably do a lot of, which is telemedicine and telehealth. I'm specifically talking about situations where the care is directed towards consumers, people at home, people on consumer devices, um, similar to probably many of the companies that we're familiar with, and that we're seeing increasing numbers of them come into the market, such as Teladoc or MD Live or those others. Um, so we're certainly seeing the online videos direct-to-consumer kind of experience grow in the market. So Teladoc, which had, I think, 1.6 million members 3 years ago, has experienced over a 400% growth to where they're claiming 7 to 7.5 million members this year. As you see in the slide, 200,000 consults in 2013, and you can kind of see the rest of the data there. I think it's also important to recognize that while those of us who've been in telemedicine for years have been clamoring for attention, both financially and others, these companies are, at least now, coming out of some funding raises, which are I find quite impressive. So Teladoc several months ago closed on an $18.3 million growth capital raise, and anybody who's seen the PR coming out about MD Live, they just closed on a $26.3 million growth capital raise through a couple entities coming together. Full disclosure, one of those was a fund that Intermountain Healthcare participates in. And I'm not advocating either one of those companies. The point is that VC groups and people who take money and put it at risk for new ventures are recognizing this type of care and this business model as attractive. And to me, that's the take-home point. There's a couple other up there on the slide that you can see, and many of these are starting to leverage what I loosely refer to as consumer-grade video conferencing equipment. You know, love them or hate them, they're out there. They work to various levels of satisfaction. But I think, again, the biggest change for those of us who've invested many of our facilities' dollars into legacy equipment such as Polycom and Tandberg codecs, we all remember the days where actually they still cost, you know, anywhere between $10,000 and $15,000 to get the higher end ones. So to see solutions coming out that allow, at least here at Intermountain Healthcare, we've set up some telemedicine clinics, you know, once we had the infrastructure in place, for, you know, a couple $100 by leveraging just consumer grade video cameras, which fit the need for that purpose. So it's quite the barrier of entry as far as financials has really come down. And to me, I just see that as an exciting trend and consider it to continue to go forward. And at this point, I really feel that the pros outweigh the cons to look at this type of equipment. At Intermountain Healthcare, one of the first things that we did was we launched an e-visit service, which is an online service that goes directly to our Instacares. And again, I'm going to be saying a lot of things that today in 2014 might seem a little ho-hum because a number of other companies have adopted these kinds of features. When we did this in 2011, a lot of these types of features that I'm going to talk about in a second hadn't been done, and some were considered impossible. So we had a couple goals that, again, you can see on the slide, and the major one was we just wanted this to be easy. And I'll explain a little bit more about what our idea was around that. At the time, we did choose Flash. Understanding all the Flash is dead mantras that were going around in 2011, everybody's first question was, if you choose Flash, you can't do it on an iPhone. We understood that, but we were trying to show some specific features, and we needed a technology that we had full control over, or at least a moderate level of control over, to do that. And Flash was really the only one that in 2011 would do that. And we did aggressively look at mobile, but at the time the technology in mobile just wasn't ready for this kind of work. We even took one of the new Windows phones at the time and pushed it to do HD video, and we literally melted the back of the phone because of the heat that we ran on the chip. That's what you get for overclocking a little bit. But anyway, and I'll talk a little bit about the key features. So if anybody goes to evisit.intermountain.com, this will be the website that you see. You can do it in any browser. It is a Flash-based application, so obviously if you're on an iPhone or something like that, you may not experience this. But the important thing we wanted to do was, again, trying to make this easy. All this website is one big button. The only thing you can do on this website is click on it. And we do have some information there. We certainly have a list of regular things that we think online care is good for. But again, it's the only thing on there is one button that says Connect Now. And we do have the ability, when the clinic closes and all the agents sign off, this graphic automatically changes to a sorry, we're closed, call back later, and then it does nothing when you click. But if you click Connect Now, the experience that you get is this. Although the form's not there yet when it first opens up. But the point is, we eliminated usernames and passwords. We eliminated subscription forms. We eliminated the need to create an account. We eliminated everything we could think of that would be a hindrance to the person trying to connect with us. And we got a lot of pushback about that, but the logic that we were using to justify that was patients don't need a username or password or a subscription to walk in our office. They don't need a username or password or an account to call our office. So why would we need to make them go through that process online? Again, we were trying to give a very positive customer experience. And you see the video up there on the left with the ability to just share text. And the area on the right is what we call the collaboration space. Well, obviously, if you have patients coming in who you've either never seen before or on a follow-up, we always have that wonderful paperwork that we make patients do. And certainly there's typically a consent to treat that if a patient hasn't signed, you need signed. Well, we didn't want to use fax machines or anything like that, so we made a tool, which we wrote, that would allow us to do a consent to treat form online. The patient can sign it, do an electronic signature online, and then we can get through that paperwork. The electronic signature is a little unique because you don't have to go out and get a token or a electronic signature account or anything like that either. It's simply the click of a button. And we did this with the lawyers, making sure we met all the international laws for e-signature, because the identity, you essentially have three parts of e-signature. You have authentication, or I should say identification, intent, and integrity. So the identification is actually handled through the video. We find out who you are the same way that we do when you walk in our clinic. We ask you who you are. And then if we may ask you some specific questions if you're already in the database. The receptionist may ask you to show your driver's license or your insurance card, and essentially you just hold that up to the camera and we take a picture of that and put it into our files. And the interesting thing about this as well is if you would, the image you have up there is of Sandra, and she works at our Taylorsville clinic. If you would get in a car and drive to the Taylorsville clinic and walk in the front door, you would be looking at Sandra. So it's the same person in the clinic that takes your call, essentially, as you would see if you walked in person. So again, just one thing that makes the process easier, and then she essentially goes through the exact same workflow process to register a patient. And as you fill out the form that you see there, Sandra can actually watch that form being filled out. And she can go in and edit the form, or she could, quite frankly, fill out almost the entire form for the patient, leaving only the signature area or an initial area, the place where the patient had to do it themselves. And that becomes important if you're doing a advanced beneficiary notice or Medicare advanced beneficiary notice, because both people need to interact with that form So this is actually a form that's much like a Google form or a Google document where both people can work on it and type on it at the same time. Now the other interesting thing is well, that kind of seems interesting, but for a typical Polycom or standard codec, that would be the end of it because they let you only go to one place. Well, we also have the ability to transfer that video call to another computer. So we can put that video call on hold, we can transfer the video call to another computer, and we can queue up incoming video calls. So if Sandra was on a video call with a patient working through a registration, and 2 or 3 other people went to the website and clicked the button, they would be told that they were in a queue, 1, 2, 3, or 4, whatever. And as the calls got answered, they would see that queue go down. But we can hold those video calls in queue while they get worked through. Again, very similar to the workflow of a traditional clinic. And at least in the Instacare experience that we're doing this now, because we can transfer the video call, Sandra will put the patient on hold, put them into a room assignment process, and when that room's available, she'll transfer the virtual patient back to a physical exam room where the nurse comes in, takes it off queue for that room, and sets it up so that the doctor or the nurse in the urgent care, who's the provider, really doesn't have to change their workflow. They go from room 1 to 2 to 3 to 4 to 1 to 2 to 3, or however the acuity indicates that they should, but they essentially open the door and solve a problem. And sometimes they open the door, there'll be we joke, a carbon-based patient sitting there like you'd expect, and sometimes they open the door and there's a patient on the computer for them to sit down and solve that problem. As they do the forms or the education and they do the e-consent, as you can see, we do give the patient back a copy of the PDF, and the electronic signature at this point also contains any pictures that we obtained in the registration process. This actually made our lawyers quite giddy with happiness because the e-signature shows the person who was on the camera, the ID that they used to demonstrate who they were, as well as being part of the date timestamp as part of the e-signature. So again, a few little unique things that we did as well. Again, so proving the impossible, before we did this, had a fair number of conversations with other video solution providers, and most, if not all of them, held some of our features that we were trying to do to be either not useful, not necessary, or just, quite frankly, couldn't be done. So this slide just kind of talks about some of the things that we did do that I've mentioned. The ability to hold calls in queue, no need to create a room, put them on hold, and the transfer process, again, which goes to the typical workflow there. The other benefit, as you can see in one of the sub-points, calls can be transferred to other Instacare clinics to load balance. Since our Instacare clinics are really one entity, and the clinicians are shared between the Instacares, we found our lawyers were okay with us transferring the patients between Instacares, because at least in that situation, there's no expectation of seeing a specific doc. You're really seeing the next up doc. So if one of our Instacares gets really busy, we can transfer those virtual patients to a Instacare that has more capacity or can see the patients sooner. We've talked about reversing that process, so if we have physical patients in an Instacare that's really busy, we could reverse that and bring the doctors in virtually, but we haven't done that yet, but it's completely possible. The other benefit is for situations where we did transfer it to a nurse, or we had a nurse practitioner model, and we've talked about doing this. If there was ever a need to escalate to a physician, or you were using a physician model and there was a need to escalate to a specialist if they were available, again, the ability to transfer the call allows for you to do that to get the patient to the most appropriate person. Now, in our particular model, now in 2014, these questions come up about some of the features that aren't there, and we admit that, and we'd love to have some time to go back and add these. So the Flash solution that we're using and the setup that we have does not do multi-chat, so we can't do 3 or 4 people on a single call. Flash itself does have the capability to do that. We just didn't put that piece of the code in. We felt that was kind of already done and not something that we had to really focus on, but we kind of wish we had and wish we had it now. One of the other challenges is that it does not currently integrate with the telephone or VoIP system. So in situations, our receptionists would have a call coming in on the computer and at the same time the telephone ringing. So that creates some inefficiencies because it's hard for them to do both, and then one's kind of creating a background noise to the other. So if any of you do this, you might want to ask that question or consider that. And it doesn't connect with the older hardware on the H.323 stack. At least in 2011, that was a real challenge. There's some solutions out there now that make this a lot easier, but again, we haven't gone back and retrofitted that into that. But something to be available, or at least I should say aware of. And then the mobile solution technical capabilities. We go back to the mobile conversation usually about every 4 months. As new equipment comes out, new technologies come out, and the mobile devices become more and more powerful. We can do the signal on the mobile. We're still not quite satisfied that it's good enough for us to really embrace wholeheartedly. We're still trying to figure out how to prevent having the up-the-nose conversation with people, or the lenses giving you that Jay Leno, all apologies to Jay Leno, that huge chin, weird-looking forehead that you sometimes get with some of the lenses on the phones when you're holding them so close to do chat. But yeah, it's also possibly because we've been using Flash, and we do understand that Flash is a very processor-intensive codec and has very large packet sizes. And there are newer codecs out there that we actually are playing with and like much better, which allow us to have a much more efficient service and get different levels of quality. One of the questions that we get asked a lot is, what can you use this care for? And I think if you had a chance to see that initial graphic that we posted on the website, we kind of outlined a lot of the lower acuity kind of things that we had expected people to call in for. And when we did our first initial launch, we didn't restrict people from calling in, and I guess we got what you'd expect us to. People called in for everything. In one sense, we were okay with that because from a clinical perspective, every patient experience, unless you're comatose or can't communicate, starts out with taking a history. So no matter what it was, we were always able to at least get a history and direct the person to the most appropriate place. Well, at least that was our strategy. And as you can see, the distribution of the types of patients that we're seeing online, the one that really surprised us, and even me, was that 19% of our patients were billed at a level 4. And 49% at level 3, and as you see, the others. This maps almost directly to a typical distribution of our primary care clinics. And that was kind of a real eye-opener to us. We also did a follow-up of trying to assess in a HIPAA-compliant manner if these patients' issues were resolved online. We did send a number of them to live interviews. Again, being able to transfer the patient, we'd ask them at the end if they would be willing to do an interview, and if so, we transferred them to a person who did a live discussion interview with them and found very high patient satisfaction scores and kind of a lot of things that other studies have shown. But we also tracked in our system if that patient encountered anyone in our system for any other reason for 60 and 90 days. And what we found was that only 5% of the patients were seen in that time frame, and we did get permission to go look at their charts, and the things that they were seen for were not the same things that they were well, I should say the things that they were billed for were not the same things that they were billed for the online experience, leading to a conclusion that we had resolved 100% of the complaints online if you make the assumption that people for follow-up would have gone to our system. Now, if they went to another system, we wouldn't know that. Now, I say that with a caveat that we openly admit that that was luck. If we did this again, we had expected 10 to 15, even 20% of the visits, especially the more complex ones, to result in a brick and mortar follow-up to get either some kind of a more comprehensive care. The fact that it didn't isn't something that I would expect to repeat, and that's why I caution people not to take that to heart too much. It was just our experience, and just for this part of the podcast. Okay, am I back?
Back, Wes.
Okay, sorry. That'll be fun on the recording. My network just said it didn't like me. That probably means that I'm talking too much. So again, the most interesting thing to okay, you can do complex stuff. Sorry about that. Not sure what's going on there. I want to kind of circle back to the various companies that are doing this today. It's a very different business model than most of us think in healthcare. Most of us think in a very encounter-based approach of fee for service. I see you, I get paid, and that's kind of the end of it. If I'm not seeing you, I'm not getting paid. Well, many of the organizations out there, their real revenue is actually from the per employee per month contracts that are signed with the companies. And so if you're thinking about doing this at your organization, and of course I would recommend that you do, you look at this aspect of the business model as a very important piece because this is really what evens out your cash flow and is the contract that you'd really like to have in your back pocket. Depending on how you can negotiate the per member per month, you can either get a subsidized or unsubsidized per click, which is kind of back to the encounter-based approach, and work with the employer or whoever you're contracting with to negotiate how you want to cover those costs. And at the end of the day, you want to make sure that you have all your costs covered. But the value really is able to be demonstrated back to the employer based on patients that could have gone to an ER or could have gone to a primary care clinic for a much higher cost to be able to do that online for a much lower cost. And I didn't put them in here, but there's a number of case studies from those companies that are out today that you can go look at. And I'm certainly, if anybody wants to contact me directly, I'm happy to send you those links. I just didn't want to put it in this kind of a presentation. And they kind of go through how they demonstrate value back to their customers and things like that. So I'm just saying, if you do go down this road, it's really important to be aware of and really consider these per employee per month or per member per month opportunities for a couple things. One, because the seasonality issues can wreak havoc with your cash flow. For example, there's a flu outbreak in the southeast states. So a lot of these online companies, their waiting times are going up to like 45 minutes and higher. And then, so they're getting a lot of activity on the per click, but then there's times where those per click, like in the summer, are really low. So that per employee per month really helps you in your business modeling to cover your costs and keep operations going while the seasonality kind of comes and goes. If you all want to do this, there are lots of options out today. You can certainly go for turnkey solutions. United Healthcare and Optum have the Now Clinic. American Well, most of the MD Live, Teladoc, Ameridoc, and every 2 weeks I'm seeing some other one come out and advertise that they're doing this too. Most of them contract their physicians rather than own them. So it's quite, you kind of apply and get on their network, and you can typically work from your office or your home or however you want to do it. And that's certainly one approach, and probably for smaller entities or smaller practices or clinics, that's a great way to get into this space and start to learn. For larger systems, it's a bit of a tougher question. You need to make sure that any alignments are in line with your corporate strategy. Some corporations like to outsource these and just want turnkey systems, and that's great. Some rather build it themselves or pursue a strategy themselves. The biggest difference between a turnkey solution is that your clinic or your practitioners are pretty much going to be limited to the per-click reimbursement, which again works great for many people. Larger healthcare systems, their corporate strategies want to hold those per member per month contracts themselves, and if that's true, then they pursue a strategy to do it independent of some of these other companies. So it really depends on what your situation is and how much capacity you have and how you want to enter the market. You can certainly take the technology for an in-system solution, and this is one of the things that Intermountain Healthcare is doing. So we're putting video conferencing technology in every single one of our patients' rooms. So 2,800 patient rooms are getting video conferencing technology. The rationale is that allows us to accelerate the patient care process. For example, we can have an interpreter virtually sent to any patient room almost instantly. We can have obviously physicians and other members of the healthcare team, from your coordinators to your pharmacists to your educators to your nutritionists, provide services virtually when they can. Even in the same hospital, this saves time. But certainly, and we're going to allow our patients to have access to this technology. If we're not using it, it allows them to do video conferencing with their family. You can certainly have family members participate in your discharge instructions. You can bring, the typical daughter from Florida that we kind of talk about. If you're having a hard conversation with a patient, or they just want their family to participate. So we're finding lots of benefits that outweigh the cost of putting this equipment in our patient rooms. And again, with the cost of this equipment coming down so low, we're able to do it, at least for Intermountain Healthcare, at a cost that we find very acceptable. And again, if anybody wants to see what we're doing, we'll have these setups at HIMSS or the ATA. And the software that we're writing to help do this, we're committed to releasing as open source. So again, it's not something that we are trying to sell. We're trying to show people how to do it and hopefully provide the tools to let anybody else who wants to do something like that do it for their own organization. So I went through that pretty fast, kind of covered a lot of high ground, but I did want to take some time and see if there was any questions or any clarification, or if people would like me to go back to any part and kind of go a little deeper. My usual problem is I want to talk about this kind of stuff all day, so it's actually harder to get me to be quiet than to talk, but did want to give a chance for questions.
Yeah, this is Bob again. If you have questions for Wes, go ahead and, there's one down there, and he has a question.
Did you say the click to request a consult was integrated into Facebook? No, it's we haven't integrated into Facebook. However, just specifically talking about Facebook, my expectation is their Skype plugin, as Microsoft continues to integrate Skype into their link environment, will be at an encryption level and usage level that will actually allow things to be launched from Facebook. We looked at this, and if we did it, we would actually use it as a launch exit from Facebook. So you essentially just have a launch button on Facebook that kicks you out of Facebook. Our security is really, really conservative. Um, but just Facebook specifically, that is how we've talked about doing it if we did it, but we are not doing that today.
Yeah, Wes, that leaves a question that I have, and of course, with the microphone, I get to ask without typing. You mentioned Skype and encryption and all that. How how do you ensure HIPAA compliance and HIPAA compatibility through your system?
Well, there's a couple aspects of that. And if you're just doing video conferencing only, um, and not using the texting piece of that, uh, there's a nice little paragraph in the HIPAA law where it specifically states that video conferencing is not considered electronic um, media as defined by HIPAA, and it's exempt from HIPAA. Now, that doesn't mean that it doesn't have to be secure, because there's, quite frankly, a lot of other security laws and best practices that we also have to follow. But the level of encryption these days, at least for the video packets and processes, is overall generally pretty sophisticated. Our own eVisit solution is encrypted at 3 points along the process. And while the NSA could probably crack into anything, we've had a couple white hat efforts come in and check those processes out and kind of got a sign off. We are currently also playing around a lot with the Microsoft Link product and going through the same process to make sure that those pieces are encrypted. So as far as the video conferencing piece is concerned, we find that pretty straightforward. The texting part that comes with most video conferencing solutions is a little more challenging. And again, HIPAA, but I would also say high-tech and actually high-tech's the one that's the one that keeps me up at night more, because of the auditing and logging and tracking pieces of it. Are usually the parts where some of these consumer products start to fall short. So if your security team considers that the chat logs need to be made available and encrypted and stored, you certainly need to be able to pull those out and extricate those from the experience. I've been in other conversations where they say, no, that's not stored and doesn't need to be stored, so as long as it goes away and it's nowhere. That to me is a little more precarious of a situation, because you actually are hitting a keyboard and creating electronic information. So at least in our efforts, we do keep and store all those chat logs whenever they happen, and store them in a HIPAA-compliant data center. But Skype, for example, had, at least for its video and stuff, that's got 256-bit AES encryption, which is a lot more, which is twice, or however you figure those. The Polycoms and Tambergs that we used, 4 or 5 years ago were only 128-bit, and there's other levels of encryption that are coming in place with the products that I see these days. I know earlier versions of FaceTime, you had to actively turn on encryption. And I have to go back and look at FaceTime, but last I looked, I think I saw that it was almost automatic these days. So it's definitely something to pay attention to, but it hasn't really been a hindrance for us. It's just been more of one of those boxes that we need to make sure is checked and done correctly. There's another question here saying, you also mentioned a few months back in the news, oh, I love it when I get in the news because I always forget what I say, that you are reorganizing your telehealth infrastructure to support a more integrated approach. Can you tell us more about that? Yeah, actually, that is kind of part and parcel with our shared accountability strategy. And actually, before I answer that question, I want to ask Bob, did I answer your question appropriately, or did you need me to clarify?
No, you did fine. I was just kind of wondering about that, and you were pretty accurate. You were pretty, yeah, you did.
Okay. So at Intermountain Healthcare, we at the time when people were creating accountable care organizations, Intermountain Healthcare kind of assumed that it had been an accountable care organization for a while. So it created its own version, um, mainly because in reading the accountable care organization design, the patient isn't identified as a central stakeholder, at least at the time when those were first coming out. So Intermountain Healthcare created a shared accountability, which was specifically to bring the patient as a central stakeholder. So in the shared accountability process, the first phase of that was a focus on reducing intra-case costs, which is a fancy way of saying making the hospital admission to discharge process much more effective, maintaining high quality, and when the patients got discharged, they were very clear on what was going on, and I guess the new uh, term of late is engaged and things like that. So the benefit there was that the telehealth infrastructure that we put into our patient rooms provided a new way to communicate in a more efficient process, not only with the people in the system, but with those outside the system who at times we would want to pull into those conversations. Um, so that was kind of how we were trying to use the communication tool to better integrate our processes, quite frankly, in and of themselves. Um, I hope that's what I was referring to in the news. Kind of lose track of the crazy stuff I say when a microphone gets shoved in my face. Um, but that's usually what I'm referring to when I talk about something like that. Did that answer your question, or what were you asking along a different line? Okay, great.
Is there any more
News is
questions?
always fun too. I say because at CES, routinely people would walk up and shove a microphone in your face and say da 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 da, and you kind of like and you say stuff. But have we looked at integrating sensors, wearables in your solution to drive more continuous care outside the hospital, as well as more patient engagement in wellness, chronic disease management? Wow, you're asking long questions. Okay, great. Now, this is a great question. Yes, we are. And again, if you have the chance to come to HIMSS of the ATA, you'll see exactly what we're doing. We are working with a company called Sotera and their Visi mobile product, which is a wearable vital signs monitor. Um, and we actually talked to a number of other companies, uh, and well, quite frankly, we're a lab, so we'll play with anything we can get our hands on, including the little baby onesie that Intel put out at CES, which we thought was cute. We weren't sure what we were going to do with it, but it looked like fun. But we definitely see this as a process, and again, not only for as the patient gets discharged and at home, but we're looking at using that inside our hospitals as well. Because they're wireless, it allows the patient to move around, and many of them are waterproof and they can take showers. But also because a number of them are coming out with accelerometers and gyroscopes in them. So it helps us track when our patients are on their left or their right for pressure ulcer reduction reporting and things like that. And most of the ones that we've been using do have the ability to give that information to the electronic medical record, which certainly is a benefit for our nurses. But we're also down the road talking about when the patients do go home, if they are deemed that they still need this monitoring, well, we just leave them on it, and we just discharge them with them wearing these types of monitors. So that's kind of one sense. But we're also very active in conversations about moving that care um, out back to the ambulatory setting where the patient in the appropriate setting and for the appropriate conditions doesn't even need to come into the hospital. So we actually, as part of the process of going to their home and providing care in the home, would put these wearables on them with most likely some type of a black box solution in the home to do the actual communication back to the network, so that we can continue that care, hopefully, and keep them healthy and not having to go to the hospital. And again, our focus has been a little bit for chronic disease management and trying to identify exacerbations before they happen. I will say we're a little, we're still in the starting blocks about using that type of solution for a wellness strategy. We, or at least let me say I in this part. I'm still struggling with the wellness data and what to do with it from a clinical standpoint. I totally understand that Fitbits and all these other wearables that relatively healthy people wear for wellness purposes are great, they're fun, they're valuable. They create their own type of data, if that's a fair way to say it. They create a lot of data. And while I'm agreeing that it has a lot of potential from a clinician's perspective, I'm struggling to identify the value of that much normative data. And I'm going to openly admit it's because I am thinking of this from a clinical mindset where I'm looking to solve a person's problem. I mean, that's just the way I was trained. Everybody in my office is there because they have a problem. So I'm actually trained in sick care. And while I understand the value of well care, it's a little outside of my my training. I do recognize the value for it, but I'm constantly trying to figure out, well, how is that information help me solve a person's problem when, quite frankly, for a lot of the time, they don't have a problem. So what I've been recommending to the organization is that if a healthcare system that's really a sick care system wants to do healthcare and wellness, you need to really start training people and hiring infrastructure that is trained on how to make that data valuable. Because I just admit that me and my brain and my training struggles with how to make that valuable and useful for me on a day-to-day basis. So there is value there, and I hope we build an infrastructure and data processes that really helps extricate the value from all that data for wellness. That was a little bit of an opinion there, so apologies if that's not the Intermountain stance.
Are there any more questions for Wes? If so, please go ahead and enter them. Otherwise, Wes, I want to thank you for taking the time to present with us today and remind everyone that this webinar will be listed on the nrtrc.org website. You'll notice that Martha has just put a link to our survey up on the screen, and I ask you to fill that out, especially to let us know what you would like to see in the future. We take this very seriously, and we want to give you what we can to help you help your patients. I don't see any more questions coming in, so Wes, thank you very much for your time, and we'll see you again in April when you present for the National TRC webinar, and we just won't let you off the hook.
That's okay. And again, if anybody has a question that you didn't get a chance to answer or something that comes to you later, feel free to reach out and email me. And again, hopefully, if you any of you want to pursue an online care, happy to talk to you in person about that or talk to you at one of the conferences.
And if you need to get a hold of Wes and you didn't manage to catch his email address, you can just contact me at bob@nrtrc.org, and I will forward your questions.
Thank you.
Thanks, everybody, for joining us, and I think with that, please fill out your survey, and we'll say thanks a lot and good afternoon.